Hey everyone, welcome to the Brain Body Reset Podcast. I'm your host, Spencer Zimmerman. Beyond the diagnosis and symptoms, there's a path to feeling better. Dive into the world of brain-body connection and learn how to optimize your health.
Are you struggling with long COVID? Maybe this started after getting the infection or the vaccine. Now, you may have been told there's not a lot that can truly be done for this. And you've probably also been told that there's just not a lot of research. I want to challenge both of these assumptions by going to the research. So I'm going to share my screen with you and I'm going to review with you a great research article, one of the best I've read on this. Now, this was published in 2025. This looks at the neurological effects of long COVID. And the reason why is because for many of you dealing with long COVID, what do you notice? Brain fog, focus concentration, finding words, memory, and others like that. Now, we're going to go to the very end of this first, and then we're going to finish here as well. What the researchers want us to do with this, where research and clinical judgment find no contraindications for multimodal therapy. Okay, so this is going to be therapy that addresses different layers, not just here's the one treatment. Integrating several avenues of such treatment may prove the best course of action. Because everyone's trying to find like, well, what's the one thing if I do it, I'm going to get better. And what the researchers are very clear is you're going to need layers to this, and you need a combination of treatments to actually help you get your life back. Now, you've got to say, what are those treatments for you? And you do that by understanding long COVID. So this is going to be a very in-depth review as we're really going to go over this from top to bottom. You're probably going to want to come back, watch this in parts. You also bring this to a provider if they're willing to fight for you, because it is a fantastic article. As it starts from the very beginning, though, in the abstract, we see lots of issues with insomnia, fatigue, mood, depression, anxiety, and cognitive impairments as a result of this. Now, there's different reasons why this may be happening. One, you've got central nervous system invasion. How is it getting into the nervous system? Two, it's going to be inflammation in the nervous system, neuroinflammation. Three is going to be blood-brain barrier dysfunction. You also have gut-brain axis dysregulation. How does the gut impact the brain? Also, you've got some vascular issues with endothelial dysfunction and how well your brain's actually perfusing. That's that hypoperfusion. So first, when we look at it, it was often believed that most people will never end up with it. But what did the CDC say? Well, it's probably about 6% of those who have COVID will end up with long COVID. But the article does say, well, you know what? This is probably an underestimate due to the challenges in even getting a long COVID diagnosis, right? There's not great biomarkers, so it's not like, oh, we test this blood marker and that means we automatically give it to you. There's not imaging. And really, there's so many different symptoms that you could have. And there's also people who may have been asymptomatic, but it was still enough to throw their system for a loop. So what are the different symptoms and how long do you have to have it? We're looking for symptoms that have been present for basically a month or longer. Now, there's 37 possible symptoms that they list, and we're not going to go into all 37 because it's way too many. But the most correlating symptoms are those of post-exertional malaise. Now, if you've been diagnosed with myalgic encephalomyelitis or posture, like, wait, I have it. Like, I already have that. How do I know it gets credit? And that's why this article is so important, because anything in this article can be applied to those other diagnoses, because post-exertional malaise is a hallmark feature of, guess what? Myalgic encephalomyelitis. Going along with post-exertional malaise, fatigue, brain fog, dizziness, GI issues. You can also have palpitations, erectile dysfunction, changes in smell or taste, cough. And then there's other things beyond that, okay? Here, you see the headaches, you see abdominal, you see muscle aches, anxiety, depression. Now, one of the most common areas that is impacted with long COVID, it's going to be the neurological system, okay? This is a common finding in symptoms. Now, this can be anywhere from mild fatigue to very, very severe fatigue. mood issues for the first time in their life, depression, anxiety, also sleep issues for the first time in their life, as well as changes in memory, focus, and word finding, right? A lot of you have brain fog and you express this to me. Now, one of the things that they found is some people develop insomnia for the first time in their life. So there's a 92% increased risk of that as a result. And then even if you are getting good quantity, which not everyone is, sleep quality on a nightly basis declines. And it's due to changes in sleep cycle. So you've got different stages of non-REM and REM sleep. Ultimately, you get changes in that. And if you don't go through your proper stages of sleep, you don't get as refreshed as you should be. And so even if you are getting 8 to 10 hours of sleep, you may feel like you got 4. And it's because your system doesn't have the ability to work through where it should. Also, new onset depression or anxiety in about a third of patients with long COVID. And this is where it really kind of annoys me as a provider who likes going to the research. So many of you, everything is being explained away on depression or anxiety instead of being like, well, you know what? I mean, why can't you have depression, anxiety from this? Instead of saying the depression, anxiety is why you're not feeling the way you want to. Brain fog is also very, very common. And people often get it with headaches, dizziness, memory issues, and others. And here, as they talk about, long COVID does look a lot like myalgic encephalomyelitis, otherwise known as chronic fatigue syndrome. But what's interesting is they also talk about cancer patients who get chemotherapy, specifically those who get methotrexate, and methotrexate's also used in autoimmune treatment. They also experience brain fog. So that's important. Next, there's a correlation between brain fog in patients with long COVID and POTS, postural orthostatic tachycardia syndrome, as well as MCAS. But we're not done yet. MCAS is linked to both POTS and long COVID. And long COVID's linked to Ehlers-Danlos syndrome, which Ehlers-Danlos is also linked to MCAS and POTS. And this is why earlier I said, if you understand what's happening from a long COVID perspective, you can apply this to the other diagnoses, because we need to stop viewing these as if these are diagnoses in isolation. These are diagnoses that share a ton of underlying mechanisms. Next, emotional functioning in patients with long COVID tends to resemble that of patients with post-concussion syndrome, another neuroinflammatory condition manifesting with headaches, dizziness, cognitive difficulties, sleep disturbances, and emotional lability. How many of you have had a concussion in the past, thought it wasn't a big deal, and now it's actually haunting you? And the sad part is, in my experience, over 90% of people are still being haunted by a concussion. They don't even realize it's a concussion. They think their concussion no longer matters because providers aren't looking at the research. And what does it say? While the neurological conditions which cause subjective cognitive dysfunction vary, right? Because there are differences. Long COVID's not a concussion. Concussion's not POTS. But the underlying mechanism which can be shared is crucial for developing therapeutic interventions, because you've been given very limited options to what you can do. You exhaust it very, very fast. Even when you go from one specialist to the next, you're hoping for a lot more than they end up giving you. And don't worry, we are going to go into the testing. We're also going to go into the treatments, they say. But it's going to be the mechanism of what's happening in this process is the most important. As we've talked about, long COVID impacts cognition, impacts daily living, ability to work. People struggle with getting back to work, as you see here. There are many symptoms that people have. And what's important to note is the symptoms of memory impairment, mood, mental fatigue may or may not correlate with imaging, neuromonitoring modalities, neurocognitive testing, EEG, functional MRI, Montreal Cognitive Assessment, and another cognitive test. So you may have explanations on your imaging or any of these other tests for it, and you may not. And if you don't have it, that doesn't mean you're a mental health case. It just means there's not a single test that is perfect. So when we look at COVID, and we'll go into this more, ultimately it damages brain cells, which are involved in different functionalities in the brain, such as your cingulate cortex, so that's attention, memory, some emotions. Hippocampus is learning and memory. Frontal cortex, this is all things word finding, executive function, mood regulation. Okay. And this injury may account for some of the issues. So, how do we know this? Well, when we look at it, you've got different testing. Now, it's important to understand that a lot of the testing we're going over, this is in research settings. It's very hard to get it outside of a research setting, and it's expensive. And that's why we have to read the research. We have to apply it, even if we can't get all this testing for patients. Now, they did a PET scan, which looked at uptake of things in the brain when they do the studies. Okay. If it uptakes well, it's a normal study. If it doesn't uptake as much as it should, that's going to be the hypometabolic. Now, they did scans 11 months after an infection revealed abnormalities and inflammation in 26% of patients. So it did it for some, not all of them, right? Now, this is seen, once again, amygdala, olfaction, hippocampus, which we already talked about, right? Thalamus responsible for all sensory relays, brainstem, which is where we see a lot of eye movement-based issues, vagal and vestibular, and then cerebellum, which ultimately has to integrate your cerebellum. Your cerebellum's integrating your vestibular and oculomotor system. Now, what else do they know? PET scans reveal increase in microglial activity in the brainstem. So your microglia are the immune cells of your brain. Now, when these get activated more, this is going to create more issues. So more inflammation, more damage, more impaired functionality. Next, MRI. There was one study that showed nearly 71% of patients exhibiting symptoms after 4 months showed abnormalities in MRI. Now, this included white matter hyperintensities. Now, white matter hyperintensities, they are more commonly found as people get older. People with chronic migraines can have it too. There's a lot of reasons this can be present. So it'd be interesting to know what was the age of the people they looked at. But either way, it still is a measure of damage that's occurring in the brain. Next, when they did a volumetric MRI, this would be through like a neuroquant. This showed reductions in gray matter thickness in the orbital frontal and perihippocampal, which is right next to the hippocampus. So once again, memory processing. EEG, so if you're doing brainwave testing, they saw a lower individual alpha frequency. So alpha is the most dominant rhythm in the brain, specifically in the back. You want it to be at 10. If it's a little above, a little below, that's okay. But if it drops too much, that's brain slowing, and you're not going to feel so great. Ultrasound testing has shown, endothelial dysfunction with long COVID. And then what they noticed with it is that reduced signal in the brainstem raphi. Okay. So this is part of the brain that's right there in the brainstem, specifically your pons area. So by your horizontal eye movements, but this is involved in serotonin. So this area is routinely targeted with like diloxetine to try to increase serotonin to help with pain. So it's done in fibromyalgia. Now, which is no surprise that we say, oh, when this gets impacted, depressive symptoms were associated with this. So there's the testing. Now, we are going to find some other tests as we go through the other things. This is more of a imaging modalities. But what's actually happening, this is what matters. If you can understand this, if you can find a provider who will piece this together, you'll have your life back. If your providers do not want to piece this together, you're not going to get your life back. And this is where the good provider is worth everything, because these researchers are doing a great job of giving us actual information as providers that we can then bring to our patients, and we can start evaluating them to get treatments. So I view it like making a pizza. The researchers have said, hey, these are good ingredients that you should consider for your pizza. Please take them and make a pizza that fits what your patient wants to eat, right? Don't give them everything because they may not need everything. Evaluate, give them what they need. And that's what we started with as we were doing this. Take what fits for the individual and then do it. The problem with so many people in medicine is they wait to be told from the researchers, here's the pizza you need to do. And you don't have time to wait for that. And this is why I don't really care the credentials of a provider. I care about their obsession with helping people. And are they going to dive into the research? Because those who do, who fight the most, they're going to have the best results. If credentials gave results in this arena, there wouldn't be an overwhelming demand for help, despite people seeing the top institutions around the United States and the world. Because people are not piecing it together. Specialists are preventing people from getting better because they're not tying in what we're going to talk about here. One, you can have changes in the nervous system through direct invasion. So we're still trying to do this, but basically you can have stuff coming in through the olfactory system, but also you get a breach of the blood-brain barrier. And this ultimately allows more things coming in the brain that it shouldn't, creates more inflammation, issues. If you have mast cells, which we'll come to in a second, mast cells also, when they're activated, dump a lot of histamine and other substances, and this opens up the blood-brain barrier as well. Autoimmune hypothesis. So COVID can look like other human proteins. Because it looks alike, this causes a mimicry, leading to things being attacked that shouldn't be attacked. Ultimately, this creates issues. Now, some of the labs that they looked at for this, autoimmune markers like anti-SSA and Rho antibodies and anti-nuclear antibodies. So this is ANA. There's also prothrombotic antibodies. So these are things that can be run by regular labs. Evidence has also emerged for the role of latent virus reactivation in long COVID. So what they found is specifically elevated responses against herpes viruses, most specifically Epstein-Barr virus, because Epstein-Barr is the most common herpes virus. So you can have an infection that then disrupts your immune system, and then a new infection or an old infection that you previously had under control can now impact you. This is why we see cold sore outbreaks with it. It's why we see shingles and other things like that. Because when the system is healthy, it keeps it suppressed. When the system is not healthy, it creates havoc. As we've talked about, mast cells, right? There's a link between mast cells and cytokine storm in long COVID cases because of, guess what? COVID triggers release of mast cells, making everything worse. And then, as we know, long COVID symptoms do look a lot like mast cell activation syndrome. And this is where, once again, it's not about the diagnosis. It's about the underlying process. And if we understand the underlying process, people get their lives back. Neuroinflammation is another big driver. What do we know? SARS-CoV causes neuroendothelial dysregulation. So this is going to be your vascular system within your brain. It causes issues with it. As a result, what happens, right? You cannot maintain the blood-brain barrier as your astrocytes get impacted. Viral infection also may disrupt the blood-brain barrier. All of these allows for immune cells from the periphery to come into the brain, creating more inflammation. So this neuroinflammatory response drives dysfunction. When you're acutely ill, it's appropriate to have it, but you should not be having a persistent neuroinflammatory response months and years down the road. And this is why when they did the PET scan, right, they still see the activation of the microglial cells. It's why it's so important, because it is able to still be there. And then, as we know, microglial cells play a big role, right? Directly and indirectly, they help with astrocytes, so that's blood-brain barrier. Oligodendrocytes, these are the cells that produce myelin, and as a result, decrease myelin of axons. Myelin basically is fat surrounding the cell that helps the speed of connections. So if you don't have enough myelin, you don't connect as well as you should. Foggy, dizzy, everything. Also, hippocampus is the one part of the brain really producing new brain cells. That's not happening. Now, are there things you can measure? The answer is yes. So there are studies that do show glial fibrillary acidic protein, which is more of a marker of astrocyte dysfunction. You can get that done. You also have neurofilament light, which is another marker. You have interleukin 6 can be ran. You have transforming growth factor beta. You have S100B as an astrocytic protein, and you have matrix metalloproteinase 9. These are all markers that can be done. Not all of them, but most of them can. Now, the disclaimer is insurance would tell you is these are still investigational and they're not going to cover them. So you got to be careful because some of these do get pretty expensive. Now, back to inflammation. Since if neuroinflammation is a driver of long COVID, creating all these issues, then guess what? Vascular endothelial growth factor, VEGF, may play a role. Now, they found that higher levels of VEGF-A have been reported, and this can ultimately lead to increase in inflammation through changing vascular permeability, which makes it so the immune cells can get in the brain and create more inflammation. So ultimately, neuroinflammation will be a positive feedback loop by impacting VEGF, which then contributes to chronic inflammation, right? So you have people who get stuck in this chronic, non-resolving inflammation. And people often think like, I had COVID, I still got to kill something, right? Or I had Lyme, I still got to kill something. Well, maybe, but for a lot of people, you don't have to kill. You have to repair. You have to get the chronic inflammatory response under better control. Blood-brain barrier, which we've talked about a lot, right? Long COVID, brain fog is associated with blood-brain barrier disruption in the temporal lobe. Ultimately, all the inflammation impacts the integrity of the blood-brain barrier, creating a lot of issues. Now, there's a lot of talk as well about the gut-brain axis, how what's happening in the gut can impact the brain and vice versa. Now, most people are not talking about the brain down. They're talking about the gut up. COVID-19 is increasingly associated with an inability to infect and disrupt gastrointestinal organ systems, okay? So what they find is gut microbiome composition was significantly altered in COVID patients compared to non-COVID. And there was this positive correlation between gut microbiome composition and circulating levels of inflammatory markers in the bloodstream. So what's happening in your gut doesn't stay in the gut. It can enter your circulation. And then, as we already talked about, if you have a leaky blood-brain barrier, guess what? That works its way in, creates more inflammation, and it drives a loop. Now, because you don't have what you should have, right? Increased persistence of systemic inflammation in long COVID patients through increased gut permeability can impact multiple organs. And as we talked about, blood-brain barrier and other symptoms. But what else do you get when you don't have appropriate gut microbiome composition? You get a decrease in the most beneficial things produced in your gut. These are short-chain fatty acids. Short-chain fatty acids play a big, big role, specifically butyrate, in helping with integrity of the gut barrier, as well as the blood-brain barrier. Also plays a role in astrocytic function, plays a role in microglia function, right? Helps regulate the immune system. It does all of these things. So having this addressed also is worth considering. Now we'll talk a little bit more about the gut in a moment. You also get vascular disruption. So as you get immune system activation, your macrophages become active. This can cause inflammation in the blood vessels, even increase the risk of coagulation issues. And that increased coagulation, guess what, can cause damage. And then, like other things, endothelial cells are not passive, right? They can actually contribute to inflammation and further coagulation, supporting that. Now, they have been able to find markers of endothelial activation in long COVID, basically suggesting, look, this is a role too.
If you're finding this information valuable, please share this podcast with others and give us a 5-star review, as that is the only way this podcast grows. Please continue listening and keep enjoying.
So what you'll see is they literally outline multiple different mechanisms that could be happening, and they didn't put in anything about sex hormones, testosterone, estrogen, and progesterone. They didn't put anything about anemia. Okay. They didn't put anything about diabetes, sleep apnea, anything like that, right? You have all of these different things are contributing to why people aren't getting better. And this is why most people will never get their life back, because everyone's trying to find the one mechanism that they want to treat. Oh, that's not me. Like, that's not me. I only treat this one. If it's not that, I'm not it. Most people are not stuck because of one mechanism. Most people are stuck because of 3 to 4 mechanisms that, when added together, is insanely profound. And it's altered physiological function. It's not a gross pathology. So what are different medications that they're doing, right? So they said Paxlovid did not do anything to prevent the rate of long COVID. Okay, so it doesn't work to treat it. Now, there's all these different medications, which I'm not going to go into, right? Steroids, NSAIDs, antihistamines that people are doing for mast cell. People are doing beta blockers for tachycardia associated with POTS. Some people are doing low dose naltrexone for brain inflammation, right? There's a long list. And some of these work, some of them don't at all. But there are different things that are being tried and considered. And most of them have very limited research. Now, going back to the gut, right? We talked about leaky gut, imbalance, dysbiosis. Dysbiosis is when you don't have the right composition in your gut bacteria. And as we already said, you need the healthy bacteria so you can produce short-chain fatty acids. Short-chain fatty acids helps prevent a leaky gut tight junction integrity. When that's not there, it can ultimately allow things produced by gram-negative bacteria, lipopolysaccharides, to enter into the bloodstream, right? This can go into the brain, create issues. And as we know, including dysbiosis, are shared by myalgic encephalomyelitis, chronic fatigue syndrome. And once again, there's so much overlap in these. We do not need to be treating these as isolated things. We need to be treating them as basically they're a family. They're a family. They share a lot of overlap in how they operate. And it's hard to help one without helping the others. And I say that as someone that's done this for years. Okay. I started first in the concussion arena. And then when COVID happened, right, people started coming to me that I'm like, okay, well, you sound like you've had a brain injury. And then I'm like, well, let's perform the same tests I do on this. I couldn't tell you the difference between someone who had a concussion and the people with long COVID with those same symptoms, because they all had vestibular issues, eye movement issues, and balance issues. What else? Right? Gut microbiome affects brain health. And even when you have a brain injury, this also disrupts the gut microbiome. So once again, revolving door. You have microclots, as people talk about. Ultimately, we've got to figure out what better treatments are. Now, there's a lot of treatments I'm doing that I find really good benefits from, but we do need more published stuff as well. So we need stuff to look at endothelial integrity, neuroplasticity, which is one of the most under talked about things for helping people get their life back from long COVID. Easily one of the most important. Viral load reduction. For some people, viruses are an issue, others aren't. This is where it gets really tricky when you're looking at your markers of Epstein-Barr virus. If you don't interpret it right, you're like, oh my gosh. And it's like, yeah, that just means you had a prior exposure. 95% of the population did. And there's not yet a good way to say, hey, your Epstein-Barr virus got reactivated and that's why you're stuck. Right? It's all really a little bit of speculation. There's also issues with ongoing inflammation as well. Which brings us to where we started, where research and clinical judgment find no contraindications for multimodal therapy. Integrating several avenues of such treatment may prove the best course of action. Once again, integrating several avenues of such treatments. We don't need to find the one thing. And it's also why I don't run the same stool testing and everything on every person. I say, what does the data and the patterns tell me? Yes, I do eye movements and balance on everyone because I find it often 80 to 90%. But guess what? Mast cell issues aren't the same across the board. Gut issues are not the same across the board. Vascular issues are not the same across the board. We have to take an in-depth history, look for patterns and clues, and then say, now let's collect the data and say what data supports it. And if it supports it, we utilize it, we treat it. If it doesn't, we move on to something else. The biggest mistake people make in this arena is they find one part of this that they highly resonate with. They try to make that their only issue. And then guess what? Now they don't have their life back. They have a lot of money that they've spent, but they're not getting better. And it's because they're trying to reduce it down to one thing. And this is where, once again, this is easily the best research paper I've read on long COVID from a neurological aspect, because they give us all the ingredients, not all of them, right? But they give us about 70% of the ingredients we need to make a great pizza. And if we analyze this and we really break it down and then we apply it, people get their lives back. And we stop gaslighting people by saying, well, we don't know what's going on. It's like, well, then maybe you should go and read the research. And how about this? If you don't want to read the research and you don't want to be up to date, how about you just retire, or you tell people you don't care? Just don't lead people down a bad path, because every time someone tries something and they don't get better, their belief that they can improve in the future goes down. And people do not separate, hey, the approach I'm using is bad versus they're bad. They just say, well, I'm just defective. When that's not true. It's the approach is defective. You're not. You just need the approach that's actually meant for you. And once again, that's what the researchers are begging clinicians to do. Do it now. Don't wait for the researchers to come out 20 years down the road and say, okay, guys, we found out what's going to help 20% of people, because that's all that's going to happen when we wait for a drug to come out for this. Till next time, I'm Dr. Zimmerman. I'm a dual licensed nurse practitioner and doctor of chiropractic. I've got a clinic near Tampa, Florida, known as Peak Brain and Body. I've got people who fly in from all over the United States and the world who work with me. I hope this helped you. Please follow me for more information.
If you have found the material valuable, please subscribe to my YouTube channel, Dr. Spencer Zimmerman, and leave us a 5-star review on Apple Podcasts or where you normally listen to podcasts from. If you would like to work with me, visit peakbrainandbody.com to learn more. You can find me on YouTube, Instagram, Facebook, or TikTok, all with the handle Dr. Spencer Zimmerman. I'm also on X with the handle Dr. S. Zimmerman 5. This podcast is for general information purposes only and does not constitute the practice of medicine, nursing, or other healthcare professional services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials are to be used at the user's own risk. The content on this podcast is not meant to be a substitution for medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition that they have and should seek the assistance of their healthcare professionals for any such conditions.